Hello, I'm John Battle with Paul Battle Senior Care Advocates. Paul Battle Senior Care Advocates provides care management and coordination services for seniors and persons with disabilities in Central Oregon. I'm going to talk to you today about some of the challenges of senior health care in the United States, ways to address some of these challenges, and how we can help families deal with the stress of managing their loved ones' care. A greater number of people are living longer, healthier, and more active senior years than ever before. People's expectations and goals are changing accordingly as they progress through the later stages of life. I'm going to tell you a true story about a client of ours I'll call Mary. Mary's a lovely lady, married to the love of her life, and lives with her husband in the dream home they've owned for more than 20 years. Mary and her husband were married soon after he got out of the Army at the end of World War II. She's in her early 90s and in relatively good health, but she suffers from osteoporosis, which causes her chronic pain. She's not as physically active as she used to be, and has become socially isolated and was severely depressed. She has multiple doctors treating her, and like most seniors, takes several medications. One of her doctors recently changed one of her medications, and she did not understand his instructions to stop taking the medication it replaced. She continued to take both medications, which led to a drug overdose that put her in the hospital. Mary's daughter is a healthcare professional, but she lives out of the area. She recently retired herself, is in the process of selling her home, moving to a new community where she and her husband plan to retire, and buying a new home. She wants her parents to move closer to her and into assisted living once she is settled, but right now she just can't deal with all the changes going on in her own life and take care of mom and dad too, so she called us. We went and saw Mary and her husband. We did an assessment and we got all of her medical records, which took a little detective work because Mary couldn't remember all of the doctors she had seen. We quickly realized that she had two doctors treating her for the same problem, had performed the same procedure on her, and were not aware of each other. Mary didn't realize they were treating her for the same thing either. Mary's husband is her caregiver, and in our caregiver assessment we realized that he has early dementia that his doctor had not picked up. We got her husband evaluated and under the care of a neurologist for his dementia. We got all of Mary's doctors communicating well and got her medication sorted out. We worked closely with her doctors, did some medication trials, and got her pain and depression under much better control. We got her back to exercising and doing some of the social activities she used to enjoy. Her daughter still wants them to move closer, but for now they're doing great at home. We continue to manage their medications, check up on them regularly, and keep their daughter up to date. They call us before they call their doctor if they have a problem because we will typically see them the same day. Mary recently had an episode of pain and swelling in her ankle and called us because she couldn't get an appointment with her doctor. We went and saw her and were concerned she may have fallen and fractured her ankle or had an infection. We ordered labs and x-rays and had her seen by an orthopedist the same day. We were able to provide exceptional care and avoid a long visit to the emergency room. Her daughter says she used to worry about her parents all the time and argue with them about their care. Now she says she can just be their daughter and love and enjoy them. I'm going to talk about the increasing population of seniors in the U.S. and the growing shortage of caregivers to take care of them. I'm going to talk about the crisis in healthcare in the U.S. and how it particularly affects seniors. And I'm going to discuss how senior care coordination and geriatric care management can help. We have entered a perfect storm of senior health care. This is a graph of the birth rate in the U.S. over the last century. The birth rate declined in the 1930s and early 1940s, leading into the Depression and through World War II. Then during the prosperity of the late 1940s through the 1950s and into the early 1960s, we got a little frisky and made up for lost time. There were 77 million babies born between 1946 and 1964. These are the baby boomers, who today are between 52 and 70 years old. For the next 18 years, roughly 8,000 Americans will turn 65 every day. Notice that since then, the birth rate has continued to decline, which means there are fewer kids to take care of us boomers in our old age. During that same period, life expectancy has continued to increase. In 1930, life expectancy in the United States was about 60 years. Today, it's over 80 years. We've been very effective at treating or preventing infectious diseases such as polio, smallpox, and influenza, and chronic diseases like heart disease, cancer, and even AIDS. Today, more than 53,000 people in the United States are over the age of 100. With people living longer, dementia is the next looming epidemic. More than 5 million people in the United States have Alzheimer's, and it is expected to increase to more than 7 million over the next 10 years and nearly triple to 15 million by 2050. And Alzheimer's only accounts for 50 to 70% of dementia, so the total burden of caring for dementia is much larger. At roughly $200 billion, the annual cost of dementia in the United States is now greater than either heart disease or cancer. Who's going to take care of these people? Demographics in the U.S. have changed dramatically since World War II. There's far more mobility, with people moving away from their hometown to follow education or employment opportunities. Many families are dual income, with both spouses having careers. There are more single-parent families. And as the previous slide showed, there are simply fewer adult children to help share the burden. It's estimated that by 2020, we'll need nearly half again as many caregivers as we have today. We have this huge cohort of boomers living longer, many with dementia, and not enough caregivers for them. What about our healthcare system? There's been a growing shortage of primary care providers for more than a decade. Roughly 50% of today's doctors are over the age of 50 and will themselves be retiring soon. The Affordable Care Act made roughly 30 million new patients eligible for health insurance. Now that they have insurance, they want to use it and receive the care they've been putting off. Medical schools have discouraged students from going into primary care for many years because the current reimbursement system favors specialty practices. Most young doctors have substantial debt, and the reimbursement for a typical office visit is barely enough to keep the clinic open. Most clinics deal with this by keeping visits short and seeing more patients per day. But 15-minute visits simply aren't adequate for most senior patients. They often have complex medical problems and take multiple medications. They typically have multiple providers who sometimes give conflicting orders. The patients often don't remember their own medical history and are easily confused. And they often don't remember what happened during their doctor's visit after they leave the office. When I was working as a primary care provider, I once had an elderly patient come to my office with a paper grocery bag full of prescription medication bottles. He told me that various doctors had prescribed them for him, and he was confused about what he should be taking and what they were for. He asked me to explain them to him. I was shocked because he was my regular patient and I had no idea he was taking all of these medications. Some were old prescriptions from doctors I didn't know. I was scheduled to spend about 10 minutes with him. That visit took much longer. Almost 90% of Americans over the age of 65 take prescription medications, and people over the age of 80 take an average of 18 prescription medications per year. 28% of senior hospitalizations are the result of problems with prescription medications. So, this is the perfect storm. A growing population of seniors living longer and dealing with dementia, a growing shortage of caregivers, and a healthcare system in crisis. The children of our seniors belong to what is known as the sandwich generation because they are being squeezed. Like Mary's daughter, they have careers, they have spouses and children of their own to care for, and suddenly find themselves caring for their elderly parents in a complex healthcare system they don't know how to navigate. The Institute for Healthcare Improvement developed their triple aim to guide healthcare reform in the United States. The three goals are to improve the overall health of populations of people, to reduce the per capita healthcare costs, and to improve the perception people have of their healthcare. One of the cornerstones of achieving the triple aim is increased care management. Having trained healthcare professionals to follow up and monitor the health of the people who are the sickest, the most frail, and the most vulnerable. Care management is generally seen as one of the most effective ways to improve healthcare outcomes and reduce cost. And yet, care management is not covered by Medicare, Medicaid, or most commercial health insurance. The primary goal of care management is to maximize the health and functional capacity of patients. This means helping them maintain their health by slowing the decline of progressive disease, or to help them improve the management of chronic illness that is not well controlled. The next major goal of care management is to help maintain the patient's independence while keeping them safe in their environment. Social isolation is often a significant problem. Seniors often understandably want to stay in their home, but they can become very isolated and are often much happier and safer in a senior community. Getting to that point is a process, though. Other important goals are controlling costs and helping families figure out how to pay for care, preventing caregiver burnout and preventing health decline of the caregiver are challenges, and managing family stress, especially with the sandwich generation we talked about earlier. The geriatric care management process is truly holistic. We begin our process with a comprehensive assessment of the client's medical, social, emotional, and psychological history and their financial situation. We assess their living situation and the family dynamics. We assess the caregiver as well. We address the needs of the entire family. Your primary care provider is focused on their individual patient. Remember that 15-minute visit? Privacy laws limit what they can communicate to the family. Based on this thorough assessment, we develop a plan of care to meet the needs of the client within the resources and needs of the entire family. We help the family make the decisions to implement that plan, and then continue to monitor the outcomes and reassess the situation to make sure the plan is meeting the goals we identified. We adjust the plan as needs and resources change over time. We are first and foremost patient advocates and problem solvers. A big part of our job is coordination of care and benefits. Seniors often have several doctors who don't always communicate very well. We help make sure that they all know what is going on with the client and that the treatment they are providing is consistent. This includes helping avoid medication or treatment duplication or interactions. Similarly, benefits are very complicated, and so we connect families with the right resources to make sure they are getting the benefits they are entitled to. Sometimes advocacy is making sure patients don't get treatment they don't need or want. I have a client with advanced dementia who had a kidney stone. She was unable to make decisions for herself and had a court-appointed guardian. She was treated appropriately for the stone, and it passed. The doctor who was treating her followed up and noticed she still had some blood in her urine. In an otherwise healthy person, the standard of care is to follow up with invasive testing to rule out bladder cancer, and this was recommended by her doctor. When she was still cognitively intact, she had signed an advance directive that indicated she would not want treatment for the cancer even if she had it. Her guardian contacted me for guidance because she did not think this uncomfortable test that the client would not be able to cooperate with was appropriate. But as her guardian, she was worried about the potential liability if she refused it. I advocated for the client to avoid this painful procedure to determine whether she had a condition that she would not get treatment for anyway. We monitor our clients' nutrition. Often seniors' diets become quite unhealthy because they have difficulty shopping, or declining mobility makes cooking more difficult, or they just don't feel like cooking when they're alone. This can become particularly problematic if they have chronic illnesses such as diabetes, hypertension, or heart failure. We look at the entire home environment and assess it for safety issues like fall risks or security if they have wandering behaviors. We look at whether they can get help if an emergency occurs, or could they get out of the house if there was a fire. We recommend changes to help them age in place, or help them make the transition if moving to a higher level of care is the better solution. Sometimes the family doesn't all agree on the best plan, and we help them come to an agreement about what is best for their loved one. We help the client avoid isolation by staying engaged in their community through social activities. Transportation is often an issue, and we help them find solutions that work for them. We can arrange driving evaluations to see if they're still safe driving. Independence is so important to a patient's well-being. Giving up driving is often a difficult decision. When they were teenagers, a driver's license and a car were their independence. We provide education and coaching for the whole family, and are a liaison for the family, especially if they live at a distance, to keep them up to date on their loved one's status. Sometimes it's easier to explain what we do by describing what we are not. We are not home caregivers. We do not provide hands-on assistance with activities of daily living such as bathing, dressing, and feeding. We do not provide housekeeping or simple companionship, although we often become close to our clients and they look forward to our visits. We do not provide skilled nursing such as wound care or home infusions, although as nurses we are qualified to provide these services. We are not primary care providers, and we require our clients to have another primary care provider. We work closely with their primary care provider and other specialists. Our providers have worked as primary care providers in the past and are qualified to provide this service, and this experience allows us to understand the needs of our clients' providers in order to work more closely with them. If for some reason you do not have a primary care provider, such as being new to the community, we will act as your primary until you can get established with someone else. We are not legal or financial advisors. We are not legal guardians or conservators. We do not provide hospice or hospice transition services. We do work closely with all of these services and will help you get them if you need them. Many people use the title of care manager, but some of these people have little or no training. Certified geriatric care managers are certified by the National Association of Professional Geriatric Care Managers and are governed by a professional code of ethics and a review of conduct process. There are specific educational and experience requirements as well as continuing education to receive and maintain this certification. The providers at Paul Battle Senior Care Advocates are unique in that we have the additional training of being nurse practitioners. This allows us to write prescriptions for medications and order other diagnostic testing, which we often do in cooperation with your doctors. We can also assess and treat urgent issues in your home to help avoid trips to the urgent care or emergency room. Some clinics use telephonic care management, but studies have not shown this to be effective. For us, seeing our patients in their home is so important. We get to see if the home is clean and well maintained. We can peek in the refrigerator to see what they are eating. We can check their pill box and look in the medicine cabinet to see if they are taking their medications properly or if there are medications prescribed by providers we aren't aware of. And we can look for safety issues such as a low barrier shower to reduce the risk of falling. And best of all, we can take the time to fully address our clients' needs. Thank you for taking the time to learn more about senior care management and Paul Battle Senior Care Advocates. We hope this has been helpful in planning the care of your loved ones. Many people wonder who Paul is. My wife and partner, Susan, is Paul. Paul is her maiden name. If you would like to learn more about geriatric care management, visit the National Association of Professional Geriatric Care Managers at www.caremanager.org. There's a directory of care managers throughout the country on their webpage. If you would like to learn more about Paul Battle Senior Care Advocates, please visit our webpage at www.paulbattle.com. If you would like to discuss the care needs of a loved one and how we can help you and your family, send us an email at info@paulbattle.com or call us at 877-867-1437. We're happy to have an initial conversation in person free of charge.